All right, I'll get started. I was asked to do trauma rounds this month, so I figured I would put a little bit more of an EMS flair on it, but we do try to incorporate things and how they apply to both EMS, pre-hospital, and hospital providers, since for a lot of patients that are brought in by EMS, we all have to work together in some way, shape, or form. So there's the objectives quickly, and I'm not going to read them off because we will hit these as we go through the presentation. So what exactly does EMS do? And, you know, I don't know, some people are very familiar with EMS and how it works, and all of us live in different areas, and it's different in different areas. So some people are very familiar with that, other people aren't. You know, there's many different types. Some of us live in areas with volunteer EMS. There's paid per call, paid per run EMS, who basically volunteer their time except for when they get called on a 911 call or out on a run. There's part-time departments, so their staff a lot of them are staffed during daytime hours when most people are at work, and then during the evening they're staffed by volunteer staff. There's also full-time departments, you know, 24-hour day, 7-day-a-week coverage. There's combination that use full-time, part-time. There's departments that are EMS only. There's fire-based EMS. There's all kinds of different setups. And so, you know, if you don't know how your area particularly runs, you know, to me, as a fire and EMS supporter, that's something that we need to go out and you should probably be aware of, just to see what type of service you have in your area, what exactly do they do, what services do they provide. Because a lot of times, fire and EMS, depending on what status they fulfill, as listed here, will provide different services. You know, some departments do like child seat checks and all kinds of different things. So sometimes if you find out exactly what department and what capabilities they have in your area, you'll be surprised at what they will offer to their tax-paying citizens. So many different services are provided, many different types of services exist. And so what exactly do EMTs and paramedics do? We got a slide here, you know, depicting what Hollywood thinks we do, you know, rushing out of accidents right before the car blows up, saving the little kids' lives. You know, lights and sirens, what our friends think we do. You know, that's not every run. That's actually the exception to the rule. You know, when we're going somewhere, lights and sirens, rushing someone to the hospital. Because a lot of our runs come into this third one here, the taxi service, right? A lot of them are more mundane, you know, maybe not so emergent call that we get called out on. You know, and then we go into the bottom there, you know, what our bosses think we do, or our medical directors sleeping on cots. And then what we actually do in the bottom corner, and like I said, that's the exception to the rule, the big traumas, the big accidents. But that is a vital service that fire and EMS both provide throughout our communities. So, you know, sometimes I think in relating EMS to hospital personnel, you know, sometimes there's a little bit of a disconnect because hospital personnel have their own responsibilities, and it's very different taking care of patients in hospital versus out in the field in what EMS do. You know, some of the treatments, I remember back to a discussion I had once during a paramedic refresher, and, you know, we were talking about airways and suctioning of airways. And you know, it was very, I think, surprising to the people that we were having the discussion with that we don't use sterile gloves when we suction an airway. You know, that's just not what we do in the field. It's not a sterile environment. We try to maintain as much sterility as we can, but it's not the same as a hospital. So, you know, what do we do? Differences in treatments or non-treatments. Again, it's all driven a lot for EMS, and this is for hospital personnel to understand. It's driven by EMS protocols. So EMS have medical directors. These medical directors will approve protocols based on the level of service that they're providing, whether it's basic life support or an advanced life support squad with paramedics available. And protocol is different from department to department. Some departments will carry paralytics for facilitated intubations. Others do not carry paralytics. It's just, you know, things differ from department to department based on the services they offer and the training level of their personnel. But on the hospital side of things too, you know, sometimes they look And why is EMS bringing us this patient? Or why is EMS bringing us this patient again? And what we have to understand from the hospital perspective is, when that person calls 911, there's a duty to act for whoever that service provider is in that area. So, we can't pick and choose. We can't show up at someone's house and say, oh, you really don't need to go to the hospital, so we're not going to come. I mean, that's not a choice we have. So sometimes as frustrated as hospitals get with frequent flyer patients coming in, or, why is this patient even coming here? We experience the same frustrations on the EMS side of things when we're called back to the same houses on a repeated basis. Not saying, if they're sick, but when we get those calls and we're just wondering, why are they calling us again? There's nothing wrong with them. Sometimes we'll be out with these patients and we'll try to reason with them and explain. Maybe you really don't need to go to the ER, but you just need to go see your family doctor. But again, if the patient's insistent and wants to go, we really don't have a choice in EMS. Other times, as the last bullet there says, sometimes we're just as lost as what ED personnel are when these patients come in. So, we unfortunately see patients who, maybe don't have family support or no support available to them, that, we get frustrated and try to think, how can we help this patient? Just like we see in the ER when we're trying to set people up with services to help them out. So, it's a two-way street, though. So we've talked about how hospital people, hospital staff needs to relate and know what EMS does. It's a two-way street because EMS also needs to understand the challenges that we experience on the hospital side of things. So, when we come into the ER and we're delivering our trauma patient and the nurse is short with us and doesn't talk much and now we get offended, again, they deal with stuff just like we do in the field. So are there crowded emergency departments, demanding patients? They have in the ER, in the hospital, demanding patients just like we have as EMS providers. Patients who are really sick need a whole lot of attention, take a lot of time and effort from the nursing staff or the physicians, just as sometimes there's patients that aren't really that sick, but they still take a ton of effort to attend to their needs. So it's a two-way street. In EMS, we have bad days. People in the hospital also have bad days, and we all need to understand that. And again, we need to try to stay on the same page and be able to relate to each other at least somewhat, even though it's in two different realms that we're practicing, our trade. So in the hospital setting, for EMS, most of our interaction is with the nursing staff. From time to time, we have interaction with the physicians, but for the most part, the majority of our contact is with the nursing staff. So we'll take a look at this as nurses, the life of a registered nurse. So, there's a lot of things, just like we had the EMS slide. What's a registered nurse do? Well, it looks like they make money, or according to the hospital, maybe they waste money. What society thinks a nurse does, what's the picture painted when you all go to nursing school, right? Every patient is a smiling patient, and we're very nice and cordial to the patients and delivering their meals and making sure they're warm and comfortable. And again, that's a lot of what nurses have to do. They have to deal and treat patients very welcoming, in a welcoming manner, no matter how that patient is treating them in return. But honestly, what do they really do anymore? Is this right? A lot of paperwork, a lot of charting, electronic charting, and that can be very frustrating because, again, I think most nurses like to take care of patients. They don't like to sit in front of a computer and chart. So again, there's challenges with being a nurse, being hospital staff, just as there is with EMS providers. We face a lot of the same challenges. So, as an EMS provider, sometimes we don't understand when we're bringing a patient in, why does the hospital staff want us to do this? Or why are they asking us these questions? So, do they really want a copy of our run sheets? They don't care about our run sheets. That tends to be a perspective that EMS providers have. We do what we do in the field. That's separate from the hospital, but that's not the truth. Because on the hospital side of things, we do want that documentation because that becomes a part of the patient's medical record, and we'll talk about that in a little bit here. Sometimes, I hear from EMS providers as they're bringing patients in, I called in report, and all that nurse kept doing on the other end of the line was asking questions. Why are they questioning my treatment? Why are they questioning what I've done in the field? And as EMS providers, we have to understand that when you're a hospital person, whether it's physician, nurse, whoever's answering that phone on the other line, sitting in the ER, it's very hard to picture exactly what we're dealing with at the scene as an EMS provider. For those of us that have done scene work, that have been out on those scenes, Jerry, when she used to fly, she has a hospital background, but she saw those scenes out when she was flying with us at Life Flight. Sometimes until you get your foot wet in that realm, it's very hard to picture what these EMS folks have to see and deal with at the scene. So, I guess my description always is, it's not that they're questioning us or questioning our patient report, but they want that picture painted. If we as EMS personnel do not paint a good picture of what we're seeing at the scene, then I always advocate for hospital personnel, ask questions, try to get that picture painted for you so you can see, EMS is bringing in lights and sirens, a patient, but this patient's alert-oriented, talking to us has a GCS of 15. If I don't do a good job as an EMS provider painting that picture, they're not going to have a clue why I'm coming in lights and sirens hot with this patient. To where if I paint the picture, this patient's is stable now, but here is the mechanism of injury. Here's what we have seen at the scene. And start to paint that picture, it makes it very much easier for hospital personnel to understand why we're treating this with a higher level of suspicion. So, why do they keep asking questions when I was calling report? Are they questioning my treatment? No, it's not so much that, but maybe the hospital staff on the other side is trying to figure out what's the trauma alert status on this. I have a check sheet that I have to check off here at the hospital that tells me this is what I should make this level trauma alert. So maybe it isn't so much that they're questioning my treatment, but maybe I haven't given enough information to provide them with some keys on what kind of trauma alert this should be. So let's look at that. When bringing a patient here to St. Rita's, EMS providers, this is what hospital personnel are looking at. This is the level 1 trauma alert criteria. So, if we go down the list, confirmed systolic blood pressure less than 90 at any time, intubated patients transferred from the scene, gunshot wounds to the neck, chest, abdomen, extremities proximal to the elbow or knee, GCS less than 9 with mechanism attributed trauma, acute traumatic paralysis, burns over 50%. And you guys can read down that list. But as an EMS provider, when I'm calling in patient report, if I'm not telling this to whoever I'm talking to on the other end of the line, if I'm not putting this in my patient report, I'm doing a disservice to the patient and to the hospital staff. And maybe sometimes that's why they're asking questions, because from some of the stuff you're saying, they tend to think maybe some of these things are present. But if I don't come out and say it in my hospital report, that's why those questions need to be asked. It's not questioning my treatment, but it's trying to get enough information to make an accurate assessment as this patient's coming in on what sort of trauma alert should we call. Again, when we call in a trauma, this sheet right here is what the nurse or the doc's sitting there looking at. And you can see the check box on the right-hand side. So as you give your report, any box they can check, they're going to check off, and that's going to tell us what level of trauma alert it should be. So as an EMS provider, knowing these criteria, it should be very easy for us to give an accurate assessment of this patient and get the correct level of trauma alert called. So that's level 1 adult trauma criteria. We'll look at level 2 adult trauma criteria. So if we don't hit any of the check boxes in a level 1, then we need to be looking at any of these as EMS providers to pass this information on during our patient report or even our early notification. So, has there been traumatic cardiopulmonary arrest, persistent pulse rate greater than 100 a minute, GCS less than 12, multiple injuries, burns greater than 10% of body surface area, pregnancy over 20 weeks with mechanism attributed to trauma. So any of these criteria, if we pass it on during our hospital call-in or our early notification, these things trigger a level 2 trauma alert. Additionally, there's level 2 trauma activation considerations. And, for this area, to me, this is a key area where I think a lot of our communication issues happen. This is more describing what we have at the scene. Because if we look at that, it says patients who need an immediate response for less critical injuries that will require admission or for any of the following mechanisms of injury. So this would be, in a level 2, I went back to the previous slide, I don't hit on any of these criteria, but these are the considerations as well as those listed criteria for a level 2 trauma alert. So falls greater than 20 feet, or any height if it's an anticoagulated older adult. high-risk auto crash, intrusion greater than 12 inches into the occupant compartment or greater than 18 inches in other sites of the vehicle. Death in the same passenger compartment. Auto, pedestrian, cyclist thrown, run over with injuries, high-speed crashes over 40 miles per hour. And this is where I've seen in my time here that most of the miscommunications happen. We had a run last year that, EMS, afterwards I talked to them, and they were kind of frustrated because they felt it should have been a higher level trauma alert that was called. And so I started asking them, when you called in your patient report, what kind of information did you pass on? Well, we had a 20-minute extrication. The patient had an open tib fib. There was, a pool of blood below the patient. They were alert and oriented the whole time, though. They didn't lose consciousness. As we start talking, but they kept going back to the fact these cars hit at 50 miles an hour head on. The mechanism of injury was there. This should have been a higher level trauma alert. And then I asked, did you tell that in your report? Well, no, we told them they had the open tib fib. We had pooling blood, but the patient was alert and oriented. I said, did you tell 50 mile an hour crash head on, 24 inches of intrusion into the passenger compartment? Did you pass any of that on? Because they were telling me that at the time, and they said, no, we didn't tell them that on our call. And so I pulled this up. And I said, that is the information as EMS providers. That's not patient information, but it's mechanism of injury, and it's what we're seeing at the scene. And that's how we complete painting that picture for hospital providers, what we see at the scene. We have to pass that information on. It's very pertinent. It's very important for hospital staff to be able to see through our report what we see at the scene, and then we can call the adequate level trauma alert. So, again, the last point there for hospital staff, if we are hearing this report coming in and it's starting to cause questions on our end, I wonder how bad this accident actually is those mechanism of injury there? That's when we need to ask questions. So, if we don't feel like we're getting enough information on our side of things in the hospital, we need to be asking additional questions if something's not clear. So many times, issues between EMS, between hospital personnel, come down to communication. Is it good communication? If it's good communication, a lot of times things go perfectly. But is there a lack of communication? And when we have that lack of communication or that miscommunication, not understanding what the other person's trying to say, that can cause issues with patient care, patient treatment on both sides of the equation. So, as we all know, communication is very important.
Hello? Well, how much are they asking?
Well, that's a lot of money for a deck.
Well, I hate to tell you this, but you're getting robbed. Did you hear me? You're getting robbed.
Ow! Stop!
America. So again, lack of communication or miscommunication can definitely cause problems. EMS and hospital communication, just some stats and research that's been done. The World Health Organization identified communication failures during patient handoffs as one of the 5 highest patient safety problems. So, that's that communication. As EMS providers, we hand off that patient. That's a patient handoff when we give that care over to the ED staff, because that's normally where we're dealing with delivering our patients to. In a study completed by the National EMS Office, it was summarized that ambulance crews have one opportunity to convey information about their patients to ED personnel. So, at that handoff, when EMS providers are delivering this trauma patient to our ED staff, that's our opportunity to pass on any pertinent information that we feel needs to be passed on. And according to a 2007 article published in the Journal of Emergency Medicine, they stated ED staff members remember less than half the information EMS crews give them during a verbal report or verbal patient handoff. Why is that? Well, I think there's a lot of reasons. ED staff members, whether it's nurses, ED techs, physicians, whatever it might be, they have their own responsibilities. They have their own assessments to complete. They have their own things that they have to do. So as I'm listening, to this EMS member giving me patient report, I'm also thinking about, okay, I need to do this, I need to do this, I need to assess this. So it makes it very difficult because we're not only trying to listen, but trying to do what we need to do at the same time. And also, as EMS personnel, I think we have to take some responsibility because we need to focus on the important stuff. And if I'm bringing in a trauma alert and Dr. Sheehan's standing there by the bedside and I'm sitting there saying, Dr. Sheehan, we talked to this guy. I know he's unresponsive right now, but he was talking to us at the scene and he said, he ate breakfast today. He hasn't been feeling well the last couple of days, but he was able to eat breakfast today. His bowels have been moving well lately. Does that make any difference whatsoever on patient care? If I'm not sticking to the pertinent details as an EMS provider, as I give patient report, it's very easy to be tuned out because there's so much going on. So we need to stick to the important stuff. We need to focus on that when we give these ED handoffs or the patient reports as EMS providers. So we must all ensure it's a two-way street. EMS is responsible just as hospital staff are responsible. Communication is a two-way street. We must try to communicate clearly, paint the picture of what we see at the scene. Because again, we have to realize hospital personnel are down in the ED in their rooms and they can't see what we're seeing at the scene. If my patient looks stable when he comes in, but I saw the scene and I know from the mechanism of injury or the forces that were applied that I have a high suspicion that there could be something very, very seriously wrong with this patient, I need to paint that picture as I'm calling in. Hospital staff, on our side of things, we need to ask questions. If something's not clear, we need to question it. Not from a standpoint of, did you do the right treatment, but from a standpoint of, give me more information. Tell me what you saw at the scene. And again, for EMS personnel, that's not questioning our treatment. It's trying to clarify what hospital personnel may not understand because they aren't at the scene seeing what we see. So this clear, appropriate communication requires a team effort so we can avoid mishaps.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
All right, so, as you can see, as we all know, communication failures can cause issues, right? So as EMS personnel, what can we do to help ensure that these communication failures don't affect our patient care and the patient care given to trauma patients? We need to ensure the earliest, best, most appropriate communication with the ED that we can. So number one key to me is early trauma notifications. Even if that's just a little bit of the information, as early as possible, we're getting on the scene. It doesn't have to be a full patient report with vitals and reports on all 6 patients we have. But we have to give the hospital a heads up, and we have to provide early notification, kind of painting the picture of what we see as we're walking up to the scene. Hey, we have a 2-vehicle MVC, we got 4 patients, 2 are unresponsive, head injuries, look like they're probably going to need an airway. If that's all I give, and I'm calling in an early note to St. Rita's ED, to our trauma staff or the ED docs, they're going to be very thankful for that information. That right there gets the ball rolling on the hospital side of things. It allows for hospital personnel to be alerted. If they're not in hospital, the trauma alert can be paged out. It also allows for further resources to be gathered. So, maybe we're getting respiratory coming down or whatever services we might need just from that early trauma alert. The early trauma notification does not have to be inundated with info. It needs to be an early heads up. That's what we ask it to be. And then we can give a further detailed patient report as we come in with that patient. For EMS personnel, we also need to make sure we're performing good patient assessments. So we need to assess the mechanism of injury. And again, I go back to the trauma activation criteria that we talked about earlier. If my patient is alert and oriented and a GCS is 14 and they look pretty good right now, but if I've had criteria that meet those considerations for level 2 activation that are based on mechanism of injury, I need to make sure that I'm passing that information on to the ED staff. And then I need to do a good assessment, and that includes, simple things like vital signs GCS, and I should be doing that as soon as I get to the patient at the scene. Because, vital signs GCS, they can change over time in these trauma patients. And if the first time as an EMS personnel, if the first vitals or GCS I'm checking or documenting is 5 minutes out from the hospital, what was it at the scene? We need to see that trend line. Are they trending up? Are they trending down? Better or worse? So we should be doing those simple things immediately upon assessment at the scene, vital signs, GCS, easy things like that. We want to find that baseline. So now when we get the patient to the hospital, to the care they need, we can start to see and compare things, how they were before versus how they are now. As hospital personnel, there's also things that we can do. So, to make this communication better and the care of the trauma patient better. So if something's not clear, we need to ask for clarification. If something's not said, if a report's coming in, I'm talking on the phone with the EMS agency bringing the patient in, and they're not giving me all the information I need, ask for it, And again, it's hard for hospital personnel if you haven't been out in that environment to get the whole picture and understand. But as an EMS personnel coming in, 2 patients in the back of the rig, probably, 2 of them could be critical. I have a lot going on. I got a lot I'm thinking about, trying to think back to my protocols and, following my protocols exactly as I should. And it's very easy for me to do a quick call-in and forget to pass on something that's pertinent. So if it's not there, as hospital personnel, if there's something that they're not telling me that I want to know, what was the patient's GCS at the scene? What are the baseline vitals you have? If we're not told that, we need to ask it. And, and that can be enough to jog the memory. And, you think about these multiple vehicle accidents, lots of patients, you have a lot going on at the scene as an incident commander. You're trying to make decisions, you're trying to triage, you're trying to say, okay, this patient's going first, and where are they going, and now where are we sending the next patient? So it's very easily done to forget some of the simple stuff. So don't be afraid to ask questions if something is not said, some information is not passed on that you want. And then also as hospital personnel, and I've seen this happen, just know that if the life flight pilot is the one calling in patient report, when life flight's bringing you a trauma, that means it's bad. It's a level 1 trauma alert. Because, when we're out aiding EMS at the scene, we're taking the worst patients they have. And, if we're at the point to where the crew is so busy and back that they can't call report, if the pilot is calling report to the ED and says, hey, this is the pilot, I'm just giving you a quick heads up on this patient. If the pilot's calling report, the patient's going to be a level 1 trauma activation. And that should be assumed because that means the crew is very busy in the back. So as we talk about all this stuff, let's look at some data that I've collected. So, EMS trauma patient documentation. As EMS providers, we need to document well. And we touched on that earlier in the PowerPoint, about our trauma patient documentation and making sure that that is available for the hospital staff. So remember, we talked about earlier, studies have shown that there's only one opportunity to pass this information on during that verbal patient handoff. So how can we help to compensate for that? If we have one opportunity and up to 50% of what we pass on is forgotten or not remembered, how can we compensate for that? Good documentation and the key is we have to do good documentation and make sure that our trauma patient documentation is given to hospital staff and stays with that patient. Because if it's done, now it's there as a record for the ED physician, ED nurses, ED staff, our trauma surgeons. They can review that information. If something does not get passed on, or if they come down and they're asking questions and EMS is already gone and the ED staff says, well, I don't remember what they said about what the situation was at the scene. Guess what? If that documentation is done well from the EMS side of things, and if that documentation is present, they can read the run report and they can see what we had at the scene. We should be painting that picture for them to review. So, that stuff is very pertinent. It will pass on what was encountered at the scene, what the initial assessment revealed at the scene, what initial vitals and baseline GCS were. So, that's one thing that we need to do. So we started looking at that, and this we've been actually looking at it for a while. How are we doing in this regard as EMS providers and as hospital staff, because it's a shared responsibility of making sure that that documentation gets put on the patient's chart for our trauma patients. So through our Performance Improvement Committee with Trauma Services, we've looked at this. Our goal is that on all case reviews, 90% of the time, that EMS documentation is available with the patient's chart at the time of review. So this is monitored for all trauma patients that come in to St. Rita's via EMS. And again, our goal for this performance improvement initiative is to hit 90%. Here's what we've done for the last 2 years, and this is a quarterly breakdown. So, in 2013, we showed steady improvement throughout the year, which is good, achieving an 87% level with our goal being 90, so we were very close. As we moved into 2014, we had a first quarter drop again, and then we started moving up, got back to that 87%, so very close to our PI goal in the third quarter of 2014, only to drop again in the fourth quarter. So again, that's the numbers that we've seen here, and that's what we've experienced. So for the last 2 years as a whole, our overall compliance with this performance improvement initiative is at 84% compared to our goal of 90. We need to do better, and I think EMS needs to take just as much responsibility for this as hospital personnel, because I know it's not all EMS forgetting to turn in their paperwork. Sometimes it's at the hospital and that paperwork gets misplaced or doesn't get put in the scan file. So, it's a shared responsibility. But this information is very important. It's reviewed by our ED physicians, our trauma surgeons and staff. It's reviewed by the girls in trauma services. So if at all possible, we need to complete our trauma patient documentation and make sure it gets in the hands of our ED staff. During trauma alerts, as EMS providers, we know patients' rooms are busy. Personnel on the hospital side of things are very busy, so it might be hard to find someone to hand that to. So, I've talked to numerous EMS agencies in the area, and you can see the picture up here. If no staff is immediately available, we've asked that you just go back to the physician's area. You see the clipboard rack. You find the patient's room number that you put your patient in. You slide your run report in that clipboard and clip it in there, and it will get scanned into the patient's hospital record. So, that is what we need to be doing. And for ED personnel, if somebody hands you a patient run report, we need to make sure that gets moved into the scan file. So what else can we do to help improve upon the care of the trauma patient? And this is, again, from an EMS perspective. We need to minimize trauma patient scene times, right? Because we all have heard of the golden hour. The sooner we can get the patient to the trauma center, the better the outcome should be. So, we started looking at, a couple years ago, what is an appropriate scene time for EMS when dealing with a trauma patient? What factors can affect EMS scene time? I'll throw it out to anyone in the room. What do you think an appropriate scene time is for a trauma patient for EMS? Less than 10 minutes. I somewhat agree with that. My perspective is it's very easy. Yeah, obviously the goal, if we could do every scene in less than 10 minutes, we'd be doing outstanding. But different scenes require different things, different resources. Sometimes you spend 20 minutes just cutting on a car to get somebody out. So it's hard to make a hard, fast rule that every patient should be out of a scene in 10 minutes or less, because every situation that we encounter is a little bit different. So ultimately, the less scene time, the better, and that's what we try to keep in mind. Sometimes that's going to be 10 minutes, sometimes that might be 25 minutes, but we want to maximize our speed at getting patients out of those scenes into a trauma center. So we started looking in 2013, again, through our Trauma Performance Improvement Committee, we started looking at this issue, and that's the question that I had asked, what are we going to find? Initially, I wasn't sure, but we started out with performance improvement goals of having greater than 25% of our EMS scene times be less than 10 minutes, like Gail said. We also wanted less than 25% of our scene times to be more than 20 minutes. So you guys, over a quarter, less than 10, less than a quarter of our scenes, more than 20 minutes. And we wanted our overall average of scene times, all runs included, to be 15 minutes or less. We thought, after talking about it, we thought that was pretty good goals to aim for. So over 2 years' data, here's what we found. And, the top blue line is our percentage of EMS scenes with trauma patients coming to St. Rita's that have been less than 10 minutes. And you can see we consistently hover around 30% or a little bit over. So, we're meeting our PI goal. The goal was at least 25% to be 10 minutes or less, and we consistently are around 30 to 32% over 2 years' time. Our second goal was, less than 25% to be seen times of 20 minutes or greater, and you can see up there too by the orange line. We consistently have hovered between 10 and 15% for the most part. So again, we're doing very well in that aspect. So with 2 years worth of data that we've looked at, we've seen that 31.7% of trauma patients arriving via EMS have had a scene time of 10 minutes or less. I think that's an excellent job by pre-hospital providers. Almost a third of our trauma patients coming in have less than 10-minute scene times. On top of that, we have 13.6% arriving via EMS have had a scene time of greater than 20 minutes. And like I said, it'd be nice if every patient could have a 10-minute scene time or less, but we understand situations are different, extrication's different. It's different getting a patient out of a car that's sitting on the side of the road versus a car that's 100 yards out into a muddy cornfield. We understand that. So again, with our goal being less than 25% of those runs being greater than 20 minutes, we're doing an excellent job. We're almost at half that goal. And then overall, the average scene time for all trauma patients arriving via EMS here at St. Rita's for the last 2 years has been only 13 and a half minutes. Again, our goal with that was 15-minute overall average, and we're exceeding that goal. So, I think we've done very well on that aspect from an EMS perspective.
What's the state average?
That's a good question. I do not have that data. I'm sure probably through their data collection, I bet you could at least get somewhat of an idea, but I don't know what the state average is. But like I said, I think for our rural Northwest Ohio area, I think those are pretty decent numbers. And you're right, it would be interesting to see as a whole state what the average is. So far, to kind of rehash what we've talked about, we've discussed the roles of EMS personnel, the importance of communication between hospital staff, ED staff, physicians, and EMS, the importance of early trauma notifications when EMS is out there with trauma patients on a scene, the importance of accurate documentation and making sure that documentation stays here with the trauma patient, and the importance of minimizing our scene times, and I think the good job that we have done of minimizing scene times for trauma patients. And then on top of that, we've discussed hospital staff, the importance of communication with EMS, asking questions. If something's not clear or understood, ask questions. Matching up info from the early trauma notification with what's on our sheets here so we can get the correct level of trauma alert called. And ensuring that EMS documentation gets placed in the scan file. If they hand it off to you in the ER, here's my EMS run report, make sure it gets placed in the scan file so it stays with the trauma patient's documentation. So we've discussed all these roles. The one thing we have forgotten so far to this point is really haven't talked a whole lot about physicians. So we'll move on to that. We have emergency department physicians here at St. Rita's, and I'm kind of disappointed because I don't see Dr. Levine here, but I figured he would appreciate that picture of him. With the caricature, ER docs, what do? They get blindfolded by the ER nurses, they spin them around, and then they pin the tail on the donkey, right? So then we have surgeons with their in-office consultations, and you can see Dr. Sheehan right there with his, is that your partner, the hand puppet? So, we have surgeons with in-office consultations, surgeons with scheduled surgeries, and again, you can see the point down there on the bottom. We've been talking a lot about good communication here today and how it can make an improvement on patient care. So again, when we don't all lift on 3, that patient ends up on the floor up in surgery, right? So communication is key. And then we have trauma alerts. Dr. Bowersock there trying to figure out what's a spleen and what's not. And again, you can always go to surgery.com in a true emergency, right? That's why you have the laptops in the operating suite. No, but really, I try to lighten up my PowerPoints a little bit. But, our trauma services staff, our physicians, our ED physicians, everybody does a good job. And, only through working together and having good communication for all of us, pre-hospital, hospital providers, and physician staff, can we ultimately make the biggest impact for the trauma patients that we take care of. So now I'm going to move into just a little bit of updates in pre-hospital trauma care. Talk about a couple items that have been supported by research. Some of these, for us on the hospital side of things, we might already be seeing. Some of them we probably have not seen yet, but it might be something that we see in the future. So, first thing I want to touch on is field spinal clearance of trauma patients. This is a big topic that has kind of, I think, been getting bigger within the EMS circle. When I went through medic school, it was drilled into our head. Everybody gets a everybody with possible mechanism of injury consistent with spinal injury gets a C-collar, a backboard, CID. No questions asked, everybody gets it. But even as early as the 1990s, the American Academy of Orthopedic Surgeons stated patients with a positive mechanism of injury without signs or symptoms and with a normal pain response may be treated without full spinal immobilization if approved by your medical director. So new guidelines and research have supported this progressive approach for EMS that's more of an evidence-based approach in an effort to eliminate unnecessary spinal immobilization in the pre-hospital setting. The biggest of those studies was the Nexus study that looked at over 34,000 trauma patients across 21 U.S. trauma centers. And it found that even with a significant mechanism of injury present, using simple assessment standards for blunt force trauma patients could avoid unnecessary cervical spine restrictions being placed. And we're going to get into some of those standards here in just a little bit of kind of what they looked at. There's also some more controversial studies performed. Oswald did one. And, as I was reading about this, as a 5-year retrospective study comparing immobilized patients from the U.S., I think it was down in New Mexico, versus non-immobilized patients over in Malaysia. Well, number one, that kind of makes you question, how can we compare things across countries here? But, they took the patients, they matched them for neurological ISS scores, so they tried to match them as well as possible. And through his study, he noted that non-immobilized patients, so these were the Malaysian patients, had better neurological outcomes with 11 versus 21% disability as compared to the 21% being the U.S. patients who were cervically immobilized. And then also another study was done to show increased mortality, that ended up showing increased mortality in patients with penetrating trauma and spinal immobilization. And ultimately, I think what the thoughts were after that study is the increased mortality probably came from the fact of the increase in time it takes to do cervical spine immobilization, backboarding. By the time we get all that done, it can take up to 5 minutes to adequately place a patient into full immobilization depending on the situation we have, thus delaying resuscitation and patients getting to an operating room. So, there's research out there that says, maybe we need to take a look at this. So for pre-hospital providers, are we going to stop placing patients on backboards? Absolutely not. That's not where I'm going with this. But there has been a push and research done that shows maybe in EMS we should take a more measured approach and look at this. So, there's been a push and a change with many EMS agencies and many medical directors to look at more appropriate backboarding practices. And that's, I think, where this is all going. So why is that? Well, we all know, unnecessary backboarding with patients, certain patient populations can cause difficulty breathing, can cause pain, can restrict respirations, increases the risk of aspiration if they vomit, if we don't have an airway present. So many EMS agencies have implemented measures to respond to some of this research. And again, it doesn't mean we're stopping C-collars and backboards. It just means we're going to assess our patients a little better, which goes back to what the American Academy of Orthopedic Surgeons stated. Patients without signs or symptoms, assess your patient. We have to look and put our hands on our patients and assess them. So here's an example of what we're starting to see pop up in EMS. This comes from my neck of the woods in Mercer County, but this is our spinal clearance checklist. So, we go through this checklist. If we can check every box no, then we're okay to not put spinal restrictions in place. That doesn't mean I have to do this. It just gives me the option. If I assess my patient, so what are the questions we're asking? There's 10 of them. Is the patient unconscious with a potential mechanism of injury? If the answer to that's yes, they get C-collar, backboard, C-spine precautions. Is the patient disoriented or have a GCS of less than 15? I have to answer all these no in order to not backboard the patient. Has the patient experienced a loss of consciousness? Is there suspicion of alcohol or drug intoxication? Is this a possible acute stress reaction? Does the patient have a painful or distracting injury? Does the patient complain of cervical pain or other spinal pain? Is there any motor or sensory deficit? Is cervical tenderness or deformity present? Is there pain with cervical motion? If I can answer every one of those questions no, then I can sign this, fill out this sheet, sign it off, and I don't have to put spinal immobilization restrictions in place. And again, this is kind of a new thing that we're starting to see, I think, filtered throughout many different EMS agencies. Yes, I can speak for in Mercer County, yes it does. So, and that's where that sheet came from. Another thing, a new evolving trend in EMS is TXA. And I think early last year, Dr. Sheehan did trauma rounds that he touched on TXA and how it might play into EMS. So I'm just going to take some of that and touch on it a little more. So it's been used during surgical procedures for years. Published literature has stated that the use of TXA can reduce the need for resuscitated blood transfusion after surgery by up to 33%. More recent studies, though, have focused on the use of TXA in trauma and the potential benefits of the use of TXA in pre-hospital treatment of the trauma patient. So, to summarize, and I summarized them briefly. I'm sure you guys can Google search if you want to find out more about these studies. But the CRASH-2 study was a large study done over 40 countries, 274 hospitals, and over 20,000 trauma patients. But it looked at patients who either had significant bleeding or were at clinical risk for significant bleeding. So, their parameters that they put into this study were tachycardia over 110 beats per minute, and or systolic blood pressure less than 90, along with the mechanism of injury that would make you suspect clinical risk for significant bleeding. So if the patients met that criteria, they were split into two groups. One group gets TXA, the other group gets a placebo. But with the results, they looked at mortalities. And TXA mortality, as you can see, was lower. Death due to bleeding alone was reduced by 15% for those that received TXA versus those that received the placebo. So, they started to see the benefits. And this NNT at the bottom, with clinical research, number needed to treat to affect one life. They said the number needed to treat was 67 patients. So for every 67 patients you treated, you would save one life. So that study was taken and it was expanded upon with a second study. This was done by the British military, looking at their combat casualties in Afghanistan. And in this, two groups were also used, TXA and placebo. Now for me, if I had been in either one of these studies, I would have wanted to been in the TXA group. Don't sign me up for the placebo. But in this study, they took those two groups and then they subdivided them even further. So you had a TXA group that was a transfusion group and then a massive transfusion group. And you can see the parameters on the slide. To be into the massive transfusion group, you had to have at least 10 units packed red blood cells with additional blood products. And they did the same for placebo. So they had placebo transfusion and placebo massive transfusion. But overall, the results of this study showed mortality in the TXA groups versus the placebo groups was over 6% less. And specifically looking at the massive transfusion subgroups of each, the TXA group and the placebo group, you're almost looking at half the mortality as what was seen with placebo. So again, they said all factors considered, the number needed to treat was 7 patients to affect one life. So again, good results showing that this can be a benefit and work well in the pre-hospital environment. So are there risks associated? Yes, there are. Matters showed an increase. I think CRASH did not identify any identifiable increased risk, but Matters showed an increase in DVT and PE in the TXA treatment groups. But guess what? If I don't bleed out, if I live to get a DVT or a PE, I can be treated for that, right? I'd rather have that negative side effect than bleeding out because I don't stand a chance then. And they said when given during the proper time frame to the proper trauma patients, TXA has shown that can be of great benefit. It's not cost prohibitive. A lot of times EMS agencies buying their own meds or supplies always want to know about costs. A typical 1 gram dose of TXA costs $45 to $55. The U.S. military has made it a recommendation in their Tactical Combat Casualty Care Guidelines. It's now a Class 1 recommendation, so they believe in this treatment in a pre-hospital environment. And then other items of note for EMS, and this was talked about by Dr. Sheehan when he talked about TXA, it only makes sense in pre-hospital environment if we have support of ED physicians and surgeons who are willing to continue it. Because it can't just be me in the EMS field giving it, but it has to be supported by the hospital where these patients are going to be going so that maintenance doses can be given. So when we look at it, it is being used in pre-hospital setting right now. This is something we have not really seen yet in this area, but I think we eventually will. Columbus area fire and EMS are using it. I believe in talking with some people I know at Delaware County EMS, I think January 1st of this year, TXA went into their protocol as well. It's currently in the process of being added to the life flight protocols as well, so life flight crews will be carrying this and administering it to patients, when it meets our criteria from our protocols. So recommendations for TXA in the pre-hospital setting, inclusion criteria, time of injury has to be less than 3 hours. So that's the big thing right there. We do not give it unless time since injury is less than 3 hours. And again, inclusion criteria is patients with life-threatening hemorrhage requiring blood products or massive transfusion. And you can see the exclusion criteria, isolated head injury, allergic to TXA, patients already on anticoagulants such as Coumadin, Pradaxa, Levinox, Xarelto. But again, a big exclusion criteria, if the injury happened greater than 3 hours ago, now we're not going to give TXA. So, the Columbus area has already started using this. The Ohio State University recommendations for usage of TXA in the pre-hospital environment is right there. For EMS, their recommendations for EMS units carrying those in the Columbus area, give 1 gram TXA bolus over 10 minutes, and then once they get to Ohio State, then they give 1 gram of TXA and 500 cc's of normal saline over the next 8 hours as the maintenance infusion. So, it's being done in Ohio. I think we'll start seeing more and more in the area, and it's proven that it has benefits. So that's the update that I had. As you can see on the slide there, my boys did not want to use TXA on their 2 trophies there. They would have been very upset if we had saved those things' lives. But does anybody have any questions?
Just an FYI, the last documented state trauma database had the average steam time for Ohio is 15.5 minutes, and those greater than 20 minutes were 21%.
So we're beating the average. I'll repeat for the online viewers. Cindy looked up. She has access to all kinds of stats and data from the state of Ohio. Average scene time for the state of Ohio was 15.5 minutes. And in this area for patients coming to St. Rita's, we're at 13.5. And you said scene times over 20 minutes were 21%. And we're hovering around between 13 and 14%. So I think it just reinforces the good care that's being done pre-hospital here in the greater Lima area. Any other questions? All right, that's all I got.